It's kind of funny listening to the introduction because I have a Duke and UNC, connections, and there's a little bit of sports rivalry there, and then Michigan and Ohio State rivalries as well. But it's really an honor to be here on Father's Day, and because it's Father's Day, I'm going to feel like uninhibited from making stupid Father's jokes, dad jokes, if everyone's quiet. So consider that a warning. And most people, you out there are in the mezzanine, but very few people up here in the orchestra. But hopefully this will be an interactive session. And Janelle told me, I think you said I have 4 hours for my comments. So if somebody,
but drink water. So whenever your voice runs out, you're done.
So good. Make sure you lock those doors. Thank you, Angel. All right. So first, my disclaimers. Anything I say is going to just reflect my thoughts, not necessarily those of the American Academy of Pediatrics. At one point I would have said the advisory committee on heritable disorders in newborns and children, but that's no longer with us or any other organization. I guess I said also sadly disclose that I have no financial conflicts of interest. So, I think about things really as a pediatrician oftentimes in the sort of policy arena, forget that there's families involved. And I've really been trying to think more about how to consider outcomes for the families along with outcomes of the children. And that's what I'd like to talk about in the next little bit. And I don't have the answer to the stuff that we're going to talk about. Looking across the room, how it has been really helpful in sort of informing my understanding, as has Lisa and Angela and other people in this room. And so, anyway, I hope you help me work through this. If I can say it, actually, I think that's what I feel like you gave my sort of tip. All right, so how about why did the golfer bring 2 pairs of pants? Exactly. Now I can come up with how about I have to think through stupid jokes. How many years does Mr. Spock have? Oh, he's got something. 3. The left ear, the right ear, and the final frontier. See, there you go. You may know them, but you're going to be telling other people. The sad thing is I have a million of them. All right, so we're going to talk about prevention. I'd like to just sort of establish a framework for us to think about the different areas that we can hit with prevention. So there's some people talk about primordial prevention, so just doing things to avoid the presence of the risk factors altogether. There's primary prevention, which is usually where I think about things the most. That's avoiding the condition by elimination of the disease agent. We're trying to increase resistance. Secondary prevention, I think about that one as well, which is addressing the condition early before symptoms develop. And then there's tertiary prevention, which is reducing the harms of the condition. That's when we talk about tertiary prevention, we're sort of getting into disease treatment and those kinds of issues as well. But just to understand that there's different levels you can hit prevention in. And we hear people talking about prevention, just try to think about sort of at what level we're thinking about. The other thing, whenever I talk about prevention, I feel like I have to invoke is this notion of the life course perspective, which of course for me is one of those reasons why I love pediatrics. So you can think about whatever it is that you're trying to improve, sort of overall wellness or whatever it is, that there's to is probably this now who spent so much of the time thinking about vaccines in that category as well. And then there's the area that I spend most of my time thinking about, which is screening. So trying to figure out who might have an issue and whether or not early intervention makes a difference. Okay, does that make sense? Okay. Some doesn't. Just take it a little bit. I also want to make a distinction between what happens within the world of public health and what happens outside of public health. And then really come up with a great term for everything outside of public health. I have personal care services in here, but whatever's not public health, that's sort of what I'm lumping in there. And then there's also this notion that you should keep in mind of screening versus surveillance. So what do I mean by that? So screening is, somebody comes in and we screen them for, condition X, whatever that is. Surveillance is, there's two kinds of surveillance. Surveillance, let's get a little. If only we had that here. So there's the kind of surveillance that happens within the medical system, right? So every time a child comes in for well child care, we're going to weigh them, find out what their height is, and that kind of thing, and track that over time. Or we're going to look at how the child is doing in terms of development, right? So that's the kind of surveillance I oftentimes think about. And then if somebody, even if they're in the normal range, is like falling off the cliff, then that's going to be something that I'm going to worry about, right? There's also public health surveillance, right? So that's like collecting data to understand what's going on at the population level to see whether or not there needs to be some sort of public health or broader intervention to help the population. Can we start with public health? Does anybody know? Okay. Is that still a thing? I need to even lecture about it. So the other thing before we kind of roll up our sleeves and get into data about issues is this other thing that I have to invoke, which are the traditional screening criteria. Has anyone heard of these before? What do we have? Okay, about half. So I'm just going to go through and talk about it because whenever you bring up screening, even if you've never heard of these criteria, this is kind of like what pops into people's mind in terms of figuring out whether or not it's the right thing to do. So Wilson and Yoder put together this report way back in 1968 to think about for the WHO around how do you figure out like the screening program is beneficial. And there are a whole bunch of criteria in the report, but I'm just going to focus on the ones that are really more relevant for the things that I want to explore in the next little bit. Okay, so the other thing to know is that Wilson and Yoder, they focus on benefit to the individual, right? So they're looking at the individual being screened, not the family or anybody else. So these are the things, right? The condition is an important health problem, right? So why screen for something if it's not an important health problem, right? So an important health problem could be something that is rare but devastating, or it could be something that would be less devastating but also less rare. But you can think about what's an important health problem, to you sort of intellectually. The next thing they said is that you have to understand the natural history. And the reason that they said that there needed to be some understanding of the natural history is because if you're going to intervene, you need to figure out what's going on. What I would say in the world that I do around prevention, there's nothing natural about the natural history because as soon as cases come up, people start doing things and stuff like that. Oftentimes we don't really understand the natural history because the cases that come to attention that form what everyone thinks of the natural history are usually the most extreme versions of it, right? So we know that those conditions are sort of on at a distribution. And before you start screening for things, maybe the only cases that you know about are the ones that are more, more traumatic and more serious. So I would say that even this is one of the criteria, I would say oftentimes we don't really think about the natural history. I think I could bring you into that in a little bit because I know you thought a lot about that issue. All right, there has to be a latent or early symptomatic stage, right? And that kind of makes sense because if you're going to screen to identify if there's not this period of time where you could do the screening and find the cases, you know, if these are the kinds of things that just develop so fast that you can't really have a public health or a healthcare system screen for it, then there's really no sense for screening for it. And then there needs to be a test that's easy, acceptable, accurate, and reliable. Okay, well, that's all like easy to say, right? But like, what counts as easy? What's acceptable? You know, is it accurate, reliable? I mean, you can sort of argue around this, but you know, the thing about screening tests is that none of them are perfect, right? So they all have false positives and false negatives, and the impact of those things can be really quite variable, right? So sometimes people talk about like false negative tests as giving you false reassurance, and so imagine you get like a false negative test and you were, you know, continuing still to have whatever problem you were having, and you may like dismiss whatever the, you know, the false negative test was about. I think that, I don't know if anybody saw the recent state of articles around the DNA testing for colon cancer, where the sensitivity was really bad. And it just makes me worried about, like, you know, I mean, when I say really bad, it's like, I can't remember, it's like 7% sensitive for like a one-time test, you know what I mean? And I just worry about the people who are having like obvious symptoms of colon cancer who like, you know, test themselves and it's negative and they sort of cross it off the list. So oftentimes we focus on like the numbers of false positives, but there are like serious issues around false negatives as well. In terms of false positives, you know, how many people have like experienced a false positive test at some point in their life on something, right? And it's like, I'm surprised that more people aren't saying it. Maybe it's because I'm like older and I was like, that's more opportunities to get like false positive tests, right? I would tell you that like I'm like, I make my primary care doctor crazy because I've gotten the PSA testing, right? So that's the test for prostate cancer that, you know, it's a blood test. And I just know that for me, if it came back positive, the overwhelming likelihood is this would be false positive because of my family history and all that. And I'm willing to like take the chances, you know. And my primary care doc, that's like one of those Pediatrics is the percentage of people that get the so like I would have hell out of them, but I just don't want to know it. And I have another story about genetics that we can talk about later. But false positives, they, you know, there are studies that go back to like the 60s and 70s showing the harm that can have on families in terms of always wondering really whether or not there's a problem with their child. I'll say though, in contrast to that, there have been some nice studies that have been done around women who have false positive mammography, and it's probably, you know, for the right, you know, subset of patients, it's not as harmful as some people make it out to be. So I think it sort of depends, but we have to think about like the impact that the false positives have. And then this is really one of the big issues too in terms of evaluating screening, whether or not the treatment is more effective at starting early. First of all, like people have to be willing to do whatever the treatment is, otherwise, you know, like what's the point of doing it? Has anybody ever heard of Happy Angels before? I always have to give her credit. Happy Angels is like just an amazing pediatrician who was for quite a long time the editor of JAMA, and she had this great line that I so wish that I had come up with, which is ordering the screening test is like picking your nose in public. You have to know what you're going to do if you find something. So isn't that great? So again, I would love to see what I can. So, but there has to be something that people are going to do with it, right? The treatment has to be out there, and then you have to know whether or not the treatment is more effective if started early. That's really, really difficult for a lot of pediatric doctors, and we can talk about it more. And I think that that's one of the gaps towards making pediatric recommendations. And then diagnosis and treatment has to be cost effective compared to like not doing things. Now, if there are only people in this room conception, diagnosis, and treatment, and sort of all the things that happen. Yes. You guys probably do that, right? Look at that. It's so like, I got like these round bells, right? And that's like, I wish I'd like, if I did like a second later, I would have like round bells. All right. So there are lots of recommendations that from the policy in the United States. I don't know how those work in Australia, but maybe you can tell me later. That make recommendations around screening conditions. And this is again goes to pediatric stuff. So there's the early and periodic screening, diagnostic, and treatment benefit, or the EPSDT benefit that's part of Medicaid, which is a whole laundry list of things that should be included in screening. There's the Advisory Committee on Immunization Practices, which makes recommendations about which vaccines are recommended in this country. It's like ties of coverage. I think it's very important. There's the Advisory Committee on Heritable Disorders in Newborns and Children, which makes recommendations around newborn screening, which we're going to talk about. Right Features, which is now part of the American Academy of Pediatrics, that they make the recommendations around what happens around adult child care, the components of that. Right Features is built into the Affordable Care Act, so if you have one of these, like, it's not complicated what's covered, but one of the non-grandfathered plans, then the things that are recommended within the periodicity schedule, which I'm going to show you, which is part of Right Features, is covered first dollar. There's the U.S. Preventive Services Task Force, which was like a whole other conversation, but that group makes evidence-based recommendations for preventive services that are also covered through the Affordable Care Act. And then there's the Community Guide, which is a product of the CDC, and I'm looking at this. Do you know if the Community Guide still exists in the current environment? I should have actually looked, but the Community Guide.
So, yeah, it's, parts that are still there. The CPST is actually on hold.
So the Community Guide makes recommendations for public health interventions that improve health outcomes, so preventive stuff. Okay, look at that. See, yellow is ACIP. So, was it Friday? Everyone who was on ACIP got their walking papers, and now there are new members who are going to be starting at some point using some method to make recommendations. I'll just leave it there. And then the Advisory Committee on Heritable Disorders in Newborns and Children, which makes recommendations around newborn screening, has, it breaks my heart to say it, I'm going to say it, has been terminated. But I suspect, see, I don't know if I can just one around, but I think that, like a phoenix, it will rise from its ashes. Have they think so? Okay, that was not a ringing endorsement, but I should say it.
I think there will be groups who send it to the lab after because it's a big one.
I'm still going through the process stages there.
I know.
All right, look at that. That is quite a slide, isn't it? And I'm one of those people that hate it when people put up a slide and say, "This is too complicated, it's small for you to read." But this is too complicated, it's small for you to read. But I did that on purpose, and the reason is that what I want to impress you with, this is the periodicity schedule. These are the recommendations for the preventive services that are supposed to be part of child care, and in the columns, right? Those are columns. Columns. Those are the different ages at which point those child visits occur. And then in the horizontal lines, which like nobody can read, I'm like seeing like 2 feet away from it, I can't even read it. But those are all the preventive services that are supposed to be offered. So it's really a whole lot of stuff that those who provide child health care, pediatricians, family physicians, nurse practitioners, and so forth. There's a whole cadre of people that provide child care are expected to provide at each visit. So I do want to sort of make this distinction between newborn screening and child care. Okay, so do people know about newborn screening? Does that resonate with anyone? Who doesn't know about newborn screening? No one ever raises their hand to that. Who knows everything there is to know about newborn screening? Happily, if you don't raise your hand, I'm going to let you. Okay. So newborn screening So that's why there's this variation by state. And sometimes it's good in terms of like, testing and trying new things. But there ought to be like a way to make sure that everybody at least screens for things that we know are most effective. And that's where the advisory committee comes in. So that advisory committee that is no more makes recommendations to the Secretary of Health and Human Services, who keeps track of this thing, a list of the recommended uniform screening panel. And those are things that states are supposed to follow. So how that recommended uniform screening panel is going to work in the future is a little bit in the air. So that's newborn screening, right? Everybody with me there? And then you have well child care. So, that goes across ages, it's repeated, it's involved, there's surveillance, you take into account personal factors, but it's certainly not universal, right? Including access and variations in quality. It does give you the opportunity for shared decision making, right? So with newborn screening, you're either going to get it or you're not going to get it, but you can't just really sit around and think about what it means. And then, for most of well child care stuff, there's no public health involvement, so it just isn't a universality of things. All right, everybody with me here? All right, so this is a typical screening analytic framework, and I just want to make sure that we're all on the same page, right? So ideally, what would happen? This is you guys are researching, so and have something closer researching, right? But if you want to know whether or not screening makes a difference, it would be nice if you could do randomized trials of screening, right, and directly know. And that's sort of what, that's sort of overarching. You see that number one at the top. You could do randomized trials of screening and figure out whether that make a difference. There's very few randomized trials of screening, especially in pediatrics. So instead, typically when we think through screening, we use what we call the indirect pathway. So, you start with people you want to screen. How will the screening work? What are the adverse effects of screening? Does screening lead to early detection of the condition? Is treatment make a difference? What are the adverse effects of treatment? How is that tied to intermediate outcomes? So an intermediate outcome is like a biomarker or something like that. Things that patients and families don't really care about, but it's something you can like measure with blood or measure with some device or something like that. And then how is that intermediate outcome associated with something that people really care about, which is here reducing morbidity and mortality? That we're going to tell me that we need to think about things more holistically. So with that by way of background, here are my questions, which I would hear to answer. Under what circumstances should we screen if identification might help the family, but not the individual being screened, right? So if you ever screen a child for something where, you kind of think that there's going to be no benefit to the child, but maybe somebody else in the family would benefit, is that like a rationale for screening? And then, how much benefit to the individual being screened should there be to justify a significant burden to the family, right? So what, like the treatment is like a major pain, right? How much of a benefit does there have to be for the child to justify this sort of major pain? So I'm just trying to draw in the family. All right? So here's some things that I thought we could talk about. So environmental exposures, genetic conditions, and challenging interventions. And again, before anybody says that like on the inside kid or whatever, this is about early identification, not for those with symptoms. Okay? Let's talk about lead. Do you guys know anything about lead? Anybody? Lead? A heavy topic? All right. So here's everything you need to know about lead exposure. Okay? Lead's associated with dose-dependent harm. Okay? So the more exposure you have to lead, the worse it's going to be. Okay? For the purposes of this sort of high-level talk, think about like its neurodevelopmental impact. Okay? So you're like right? Stop the ongoing exposure. If the levels are really high, then you can use chelation. Chelation is using medication to lower the blood level, but the chelators are associated with all sorts of medical problems. And the other thing is that because lead is deposited in the bone, as you start to chelate things, you actually liberate more lead into the blood system. And so it becomes very, very difficult to do it. The other thing is that there's some older studies that question the benefit of intervention on restoring the neurocognitive impact. So these were studies like done in Boston and in other places where they had children with elevated lead levels, and they went in there and they, went whole hog in terms of getting rid of lead exposures, and then followed those children and how some of these were done in the context of randomized trials. And the sad thing is, and I really don't mean to make it light of lead, is that once you've been exposed to it and have had the neurocognitive impact of it, it's likely that the interventions are not going to restore things. Now, you can stop ongoing exposure, and you can stop things from getting higher, but in terms of like the interventions that you make, for many, the worst may be out of the barn, right? But there are other good things, right? So if you screen, right, detection could lead to protection of others who could be exposed, right? So that's kind of like using the trial like canary in the coal mine, to be a little dramatic, right? You find a child with an elevated lead level, and you go in there and try to do something to get rid of it. So here's the thing that bothers me about that. Public agencies, so not public health agencies, but like housing agencies and those kinds of things, they know where the contaminated houses are. Like I know in Columbus, I can sit down with a map and show you like where the lead is. And so if we really care about this, really dramatic thing, if we really care, probably don't give me a single on this another time, but we know where the lead is. If we really care about it, we just solve the problem. And the other thing is that apart from screening, regulation, like getting rid of lead paint, has done the biggest job. So take a look at this here, okay? So the blue line represents the average lead levels in the United States. It doesn't really matter if the numbers aren't big here to you in any case, but look how dramatically the lead levels, the average lead levels in Americans has fallen, all right? And all this was due to passage of legislation to restrict the amount of lead in the environment. Now, each time there's been a dramatic decrease, the CDC has reset the threshold of concern. But I can tell you that none of those changes were based on screening. This was all public health interventions. So you could argue, like, why do this? Maybe this is all, for naught, and we should just really focus on doing things, at the public health level, right? Now, and somebody I know, right, is going to say, who here's from Michigan? Okay. Has anything ever happened, like in the past 10 years, related to lead in Michigan? Right? It's been all over the news, right? So this is the Flint tragedy, and the way this was picked up was a smattering of kids who had surprisingly elevated lead levels, where the environmental investigation didn't put forth where it was coming from. I mean, but the sad thing is that those kids who were exposed, are going to suffer the harm. But, so you can argue, should we screen or not screen? All right, I'm going to do another couple quickly until this is like raise your hands at me, which is Duchenne muscular dystrophy. So this is a condition you can detect from newborn screening. It's an excellent condition that causes death in the second or third decade of life. Most kids with it are diagnosed around 4 to 5 years of age, and despite trying to educate people on the warning signs, the average age hasn't changed in years and years and years and years. And there are therapies that are out there, but it's unclear whether or not early intervention, pre-symptomatic intervention-based therapies. Now there are, you can treat with corticosteroids, and there are studies that go down as far as like 1 year of age, probably younger. But it looks like there's something there that could help. uncertainty about benefit to the offending child. Ooh, that's a good one. Does anyone know? Oh, yeah, tell me. All right. And then there's also this issue of cascade testing, right? So if you find somebody who has a heritable condition, a genetic condition, oftentimes you can go and find other family members who have it. And is that a benefit? I'm interested, so I'm just going to go through a couple of things. So I'm going to open it up for as much time as we have. Does that make sense, Lisa? So how about autism screening? Okay, so autism screening is recommended at 18 to 24 months of age. These, in my experience, the kids that are picked up by autism screening aren't really asymptomatic, but they're really sort of unrecognized by the family. Oftentimes these families don't, don't have any experience in the normal range of development is. So it's different than asymptomatic or even early symptomatic. These kids oftentimes really, when you dig into things, clearly have autism, but the family doesn't recognize it. But the issue is the impact of the intervention for those identified through screening only is unclear. Okay, so if you just find a child through autism screening where the family didn't have any concerns, does that lead to better outcome for that child than if you waited till somebody, thought that there was something afoot? And people get mad at me when I say this because, like, how could early intervention be bad for autism? But from a purely scientific standpoint, just the studies haven't been done of early intervention for children who were identified only through screening. And there are a lot of reasons to think about this hard, right? Because when people are asymptomatic, both for the child and the family, like, you can't get better than being asymptomatic or unrecognized, right? Like, the family's happy, and then all of a sudden you're telling them it's bad news. And then the burden of treatment for autism is not insignificant. ABA therapy, for example, can be expensive if you don't have the right insurance product. There's problems with access if you happen to live in a community that doesn't have therapists. There's intensity, there's trade-offs for the family, right? So if you're trying to coordinate this care for your child, you have another child, what happens to that child, the family downsides to the whole thing. So I think this is another example where we have to really, really think carefully about what we're doing. I think this is an example, like, in an ideal world, right, you can engage in shared decision making, find out whether that family's like values and preferences are, but there's no real way to do that in the real world. So I'm just going to end here with what should policymakers think about the potential benefits and harms for screening to the family? Is it really possible to have shared decision making in these cases, or is this just like too complicated for like your average person and your average clinician to think about making those well-child checks? Are 15 minutes in long? And then what I hope is that everybody in this room like resolves this for me, so thinking through what the research agenda is. So I'll stop. Thank you. Yeah, that was great, and I hope she resolves this for us. I think that it's still a pretty open area for.
Yeah, and I think just to add to that, your work that Ellen's doing is incredible and is highlighting, especially how any of these shared decision-making models evolve and really are required to evolve with the age of the child, and so how that looks really different across the different pediatric age groups. Other questions?
is, see, I'm like still upset about this whole thing, federal advisory committees. So federal advisory committees are open to the public. And so when, I've been working, for really decades in terms of thinking about different newborn screening topics. And advocacy groups and family members who have affected children have really driven the process. They're the ones that come with the nominations to add a condition on, and they're the ones that present the lived experience. And although we present the evidence there, the advisory committee votes also listens to, especially given all the evidence gaps, the issues around the families. What I'd say anecdotally, and these family advocates, I give them great credit for being able to, in many cases, take what's been a great tragedy in their life and trying to develop public policy to keep other family members from experiencing this. But for many of them, their worldview is based on what happened to their family. And so the advisory committee hears oftentimes heart-wrenching stories about what's happened to families, and if only, the screening had happened and early intervention was allowed, that another family would be spared of that. What you don't hear in the advisory committee meetings is the experience from the thoughts from families that haven't had those experiences but represent the general public or people who are less invested. And so, getting to your particular question, I'd like to highlight a condition called Krabbe disease, which is just it's a terrible, horrible illness where these newborns who one day look great very rapidly develop neurologic decline. They look like they're in a lot of pain. They cry a lot, and they die a really terrible death. I mean, there's just no way to say that it isn't a horrible condition. The treatment for it is a bone marrow transplant, a stem cell transplant, and that really has to be done around 1 month of age, right? So you can imagine, screen test comes back positive, then you're in the position of having to make a decision about whether or not you want your brand new baby to get a bone marrow transplant, and there is an upfront risk of mortality with that as well. It's like 10% or so. And so, in the states that have begun before the advisory committee made a recommendation to add it, but there were some states that were doing it. Of I can't remember the exact numbers, but it was like 10 cases that were identified through newborn screening. 7 of the families opted for stem cell transplant, and 3 of the families decided that they would rather just go home and be with their baby and not subject their baby to stem cell transplant. That's the kind of perspective that we would never hear in these kinds of meetings, and understanding that there's this range of perspectives on things. I think one of the reasons I'm excited to come here is I hope that this is the kind of work that you all can do, that you can raise voices that we wouldn't otherwise hear. I'm sure you probably have stories